Welcome everyone again to the University of New Mexico Law and Mental Health Didactic Series. This is a series hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences, along with the New Mexico Behavioral Health Services Division. Thank you for all of you attending today. I'm Anthony Perillo, the Forensic Psychology Training Director in the Division of Forensic Behavioral Sciences in the University of New Mexico's Department of Psychiatry and Behavioral Sciences. For our talk today, if you have any questions for our presenter, make sure you enter them in the Q&A box anytime you feel comfortable. Just know that we hold those until the end. We do try to get to as many as possible, but it's not always possible. So just forgive us if we can't get to yours. If you are pursuing continuing medical education credits, there will be a sign-in sheet in the chat box shortly. And there will be a sign-in sheet for APA continuing education credits later on near the end of the presentation. Make sure you keep an eye on the chat for that as the presentation wraps up. Make sure you open the link before you leave. And make sure you save your certificate after completing the survey, because we don't have access to copies of survey completion after the fact. As a heads up, the recording link and PowerPoint slides should be available sometime later this week. And for next week's talk in the series, we have Dr. Jenny Chan, who will be discussing working with interpreters in forensic evaluations. But let's get back to this week. I'd like to introduce you to this week's speaker who'll be discussing insights from the Transtheoretical model of change to help advance forensic mental health policy. This is Dr. Jaymes Fairfax-Columbo. Dr. Fairfax-Columbo helps develop and coordinate policy related to the intersection of criminal, legal, and behavioral health systems via an East Coast nonprofit organization. Prior to this, he was the training director of the Forensic Psychology Postdoctoral Fellowship here at the University of New Mexico and was an assistant professor in the Department of Psychiatry and Behavioral Sciences here. He completed a postdoctoral fellowship at Bridgewater State Hospital, his pre-doctoral clinical internship at Springfield Hospital Center, and his doctoral and law training at Drexel University. He's co-authored and authored numerous peer-reviewed articles on forensic behavioral health topics, as well as many magazine articles, newsletter articles, book chapters, and a book itself. Recreationally, outside of his work, he enjoys practicing Brazilian Jiu Jitsu, playing pickleball, and doing yoga. Dr. Fairfax-Columbo, Jaymes, on behalf of the University of New Mexico, it's an honor to have you returning. We're very excited to have you joining the series and contributing this discussion here. I will go ahead and throw it over to you.
Perfect. And you can see my screen that's being shared now? Great. Well, thank you very much, Dr. Perillo, for that introduction and for the invitation to come back. It's a little bit of a homecoming of sorts for me. As Dr. Perillo mentioned, I was the training director before he took over. And it's a sight to behold what he's created and how much things have grown. So it's really, really exciting. And I love that I got invited back to talk about a topic I'm really passionate about, which is forensic behavioral health policy. I'm trying to live my values a little bit too. You'll see I'm drinking tea out of my Juvenile Law Center mug, which is a very big juvenile justice policy organization in Philadelphia. And I'm also pitching my jiu-jitsu company stuff because I am a big jiu-jitsu buff. Plus, I'm just a thirsty guy. So I got tea and water going at the same time. I want to talk to you today about advancing forensic behavioral health policy. And it's not as hard as you would think because we're well equipped to do it as psychologists. And I'm going to talk to you about that via the Transtheoretical model of health behavior change. Moving through some just formality slides. Dr. Perillo also went through a bio for me. Just some housekeeping stuff here. What I want to do today is three things. I want to operationalize forensic behavioral health policy for you. I want to review the Transtheoretical model of health behavior change, and I want to apply some insights from that model into how you can be a good forensic behavioral health policy practitioner and how you can advance policy for the betterment of individuals with behavioral health challenges. The overall presentation theme for today, this is just my 2 cents, is that mental health professionals are ideally situated to function in a policy sphere. We know how to bring about change, we know how to motivate people. We can bring about change even if it's reluctant change, even if people don't recognize initially that change might be in their best interests. And when you think about what policy is, it's a lot of that. So let's turn to learning objective 1. Let's operationalize what forensic behavioral health policy is. Let's define some key terms. When I use the term forensic, I think about forensic very, very broadly. So a lot of people will talk about forensic thinking about evaluations for the course, and that is an aspect of it. But when I think about forensics, I think about APLS and all of the different subfields of psychology that are represented there. So really the term forensic, if you think about it broadly, refers to an activity related to the law or to a legal process. And that was a definition used by Dr. Dave DiMatteo in the Becoming a Forensic Psychologist book that I was able to co-author with him and Alicia Desai. So I like that broad definition of forensic. I want to use the term behavioral health. All of us as psychologists understand that the DSM contains a bunch of different types of disorders, right? We've got what you would think of as psychiatric disorders, personality disorders, neurocognitive or neurodevelopmental disorders, substance use disorders. It's all under one text. But if you're in the policy world, you know that that's not how they think about things. We often treat intellectual disability different than, mental illness, different than substance abuse, to the point that our information sharing laws are written differently. The reason I want to use the term behavioral health is to encapsulate all of that, right? So that we know we're talking about everything behavioral health, everything related to substance use disorders, anything with a behavioral manifestation in terms of how we diagnose and think about it. I also want to define the term policy. So policy refers to plans of action adopted by governments or government actors in response to an identified problem. So when I think about forensic behavioral health policy, I'm blending all three of those concepts together. But if you think about policy in layman's terms, and I'm big about thinking about, what's the simplest way to describe something? It's really just collective action to address a problem, right? Addressing something through the collective instead of at the individual level. But I want to be clear that you as an individual can contribute to the collective. Now, a key aspect of public policy is the attempt to influence it. And typically, we're thinking about how we do that via education, advocacy, or the collective action of interest groups. I want to go over the policy cycle with you. How do policy initiatives actually come to fruition? So what happens is there's a problem that presents, and then we go through a 5-step, and different models have like 6, 7, 8 or 9 steps. But the 5-step general model that people like to talk about is you start with agenda setting, right? What are we going to, what are the things that we need to be paying attention to? Then you move on to policy formulation. You move on to decision making, you actually implement the policy, and then you evaluate the policy and see if it needs to change and if it's achieving its outcomes. There are some key questions that you ask yourself at each step of the policy cycle. So when you're thinking about agenda setting, you're really thinking about what is the problem that needs to be worked on? How do we identify or operationalize the problem? When you're talking about policy formulation, you're brainstorming possible solutions to the problem. Right? Most problems have myriad solutions. A lot of problems have multiple solutions that need to work in tandem for it to be effective. And we'll talk about that in a minute when I review sequential intercept model. At the decision-making step, you're thinking about what solutions, notice I have it in parentheses with an S, right? It's not just a solution, it could be solutions. What solutions should be chosen to the problem and why should they be chosen? Why are they the best solutions, at least for that particular point in time? When you think about policy implementation, it's how do you enact that solution, right? How do you actually get it to manifest? And then when you move to the policy evaluation stage, you're thinking about a few things. Number one, is the policy leading to the outcomes that you want? But also, is it leading to unwanted outcomes? And a lot of times we'll call these unintended consequences. And there's that old saying that the road to hell is paved on good intentions, right? And you can probably all think of numerous policies where the intention behind it is good, but it has some negative externalities that are pretty salient. When you think about the key actions at each step of the policy cycle, when you're thinking about agenda setting, you're thinking about raising awareness of a problem, and you're really emphasizing the need for that problem to be addressed. Moving on to policy formulation, you're starting to brainstorm possible solutions to the problem, and you want to seek out experts to help you develop well-reasoned solutions, right? None of us on this webinar probably think that we're the expert in everything forensic psychology, right? Different people have different expertise areas, and we want to seek out people who have specialized expertise when we're coming up with these solutions. At the decision-making stage, you're making, it's self-explanatory, right? You're making a decision about which solution you want to pursue. So you're weighing the pros and cons of the different solutions, maybe how easy they are to move forward with, what barriers might be in place. When you move to policy implementation, you're effectuating those chosen solutions, right? So you've decided, hey, these are the things that we want to move forward with, but how do we actually effectuate them? How do we get them to manifest? How do we a lot of times, how do we actually spend the money that we've been given to use to address this problem? And when you talk about policy evaluation, you're monitoring the effectiveness of a program, including both the positive and negative consequences that are produced. And you're also making needed revisions to that program. And I want to draw specific attention to making needed revisions. Just because a policy didn't work out doesn't mean that you should scrap it altogether, right? There might be good things about that policy that you really want to work to enhance, but you want to sort of trim the fat on some of these negative aspects. As forensic psychologists, why should we care about forensic behavioral health policy? I can think of a number of different reasons. So you can think about the competency services crisis. Most people on this webinar are probably familiar with that, and there's been many presentations in the Law and Mental Health series relating to competence to stand trial and the competency services crisis. We can be concerned about the poor quality of forensic behavioral health services. There's any number of articles that talk about poor quality evaluations, people having trouble getting access to treatment, those types of things. Reentry and reintegration difficulties. I have a mentor who every so often, some of you probably have somebody like this in your life, they'll say something and it just changes your worldview. It just changes the way you think about something. And I used to talk about reentry, and this individual said, you know, reentry is easy. All it takes is a discharge date, but it's reintegration that's hard. So whenever I think about reentry, I always now think about reintegration, right? Truly, all reentry means is you've left that facility and you're coming back to the community. But how do we reduce your risk and help you reintegrate back into the community? Other salient examples include the opioid epidemic, right? Overdoses are at record high levels. It's really clear that we need a better policy solution to what we're seeing. Deinstitutionalization and the criminalization of behavioral health issues is something that we talk about a lot. And then we're seeing, you know, just record gun violence in some American cities, to the point where now the president has established a cabinet to address those specific, or a cabinet position to address that specific issue. So there's a bunch of issues currently that we're facing that should really concern us. And one of the things I also want to emphasize is that things are intersectional, right? It's not all, hey, a behavioral health issue leads to this problem. It's compounded by things like systemic disadvantage, right? So that can really exacerbate somebody's behavioral health issues and what they have access to and how we tackle some of these problems. I want to go over a framework for forensic behavioral health policy, and I think this is probably one of the biggest advancements in forensic psychology that we've ever had. That's just my 2 cents on the topic. But the sequential intercept model. So when we think about the purpose of the criminal justice system, and I use a lot of memes and GIFs in presentations, so hopefully you get a good chuckle as we go through. But when I ask you that question, what is the purpose of the criminal justice system? The obvious answer is to catch and punish criminals, right? Seems like a very obvious answer to people. But we have a problem, right? The problem is that we're not always catching and punishing people who have criminal propensities. Oftentimes we're catching people who have behavioral health issues. So it's known there's high rates of individuals with behavioral health issues in the criminal justice system. People are overrepresented based on the proportion of the population the general population that they make up. We're noticing now a byproduct of deinstitutionalization without creating adequate community supports, right? So for all the good it did to let people be in lower levels of care, you know, deinstitutionalization and psychiatric medications coming out, there are plenty of people now who slip through the cracks. And we only see that they've slipped through the cracks when they end up in the criminal justice system. And this is something I talk to police a lot about. When I want to build rapport with police who are concerned about behavioral health issues, I talk about the institutionalization and how it has changed the nature of what their jobs are, right? And how a lot of times they're talking about why they got into the field, which is to catch and put bad guys behind bars. And now they're responding to a lot of behavioral health things, right? And it's very frustrating. We also have increasing interest in community-based alternatives to solve this problem. So we know that incarceration is an inappropriate venue for treatment. It's hard to get adequate behavioral health and physical health treatment in carceral settings. It's expensive to keep people housed in jails and prisons. And just on humanitarian grounds, do we really want to criminalize what is a behavioral health problem? The sequential intercept model, in my mind, is predicated on appropriate use of discretion. And we use discretion in the criminal justice system every day. We used it at the police level when a police officer decides, am I going to arrest this person or deflect them towards the behavioral health system? Prosecutors use this when they are choosing whether or not to offer a plea bargain. There's technically no constitutional right to a plea bargain, even though, the vast majority of cases are resolved via a plea bargain. Judges use discretion at sentencing. They have sentencing guidelines they sometimes have to follow, but they're able to use their discretion to decide what outcome somebody should have if they're culpable. Bail or pretrial release. So again, judges, they have the discretion about, am I going to release this person? And if I do, what conditions should I release them under? Diversion. So does the prosecutor agree that somebody should be in a diversionary process, like a drug court or a veterans court? And then parole. Do you violate somebody, or do you use like a graduated approach if they're not doing super well? So we utilize discretion in the criminal justice system every day. And when I think about sequential intercept model, it's really harnessing that discretion in pro-social ways. The other underlying piece of sequential intercept model that I really like to emphasize is therapeutic jurisprudence, which is the idea that we can use discretion in the criminal justice system for the benefit of other people. It's interdisciplinary in nature inherently. It's the collaboration of not only legal professionals, but medical professionals, psychologists, behavioral health professionals, like social workers, social scientists. They're all coming together to work in a collaborative fashion, which is different for the criminal justice system because we're used to it being adversarial in nature. And it's really the study of the use of law as a therapeutic or a change agent. So as we move through the intercepts in the SIN, we'll talk a little bit about how you're using the law as a change agent. So the solution to this problem really has become the sequential intercept model. I was very lucky that I was able to do an internship in Philadelphia where I got to work closely with Dr. Patty Griffin, who is one of the creators of sequential intercept model. She had a really, really great talk at APLS because she won a contribution award. And just to hear her talk about how it was created and how it was envisioned was it was just great. So I just really want to thank her for the tutelage she's given me to help me think about things in a systemic way. Sequential intercept model is really the idea that there are 6 different points along the criminal justice spectrum where we can intervene to help link people to behavioral health services and help prevent further penetration into the criminal justice system. One of the things Dr. Griffin talked about during her talk was that it was initially going to be called the sequential filter model, right? And so if you think about filters, at each one of these intercepts, earlier on you're helping to catch more people, but if it passes through, or if they end up passing through, that you can catch them at a different intercept. A lot of people now understand this. If you think about like the Swiss cheese model of like COVID prevention, right? Where you stack the cheese up next to each other, and if something slips through, like the next thing that you did to prevent the spread could help. I think of it like that. But let's go through each of these intercepts and talk about how you can divert somebody or deflect somebody over towards behavioral health services. So intercept 0 is crisis services. And because I'm giving a talk for the New Mexico Law and Mental Health series, the UNM Law and Mental Health series, I'm going to use some New Mexico examples. This is a picture of the New Mexico crisis continuum. And intercept 0 is crisis services. The idea here is, well, there hasn't been a formal criminal justice response yet, but there's a clear behavioral health crisis going on. And if we don't intervene now before it escalates, it could end up in the criminal justice spectrum. So this was added more recently. I think this intercept was added in 2017, but it's an understanding that, hey, the community crisis system is key to helping people not enter the criminal justice system. And you're thinking about interventions like crisis helplines. You can think about 988, which is an alternative to calling 911. You could think about crisis centers, right? How do you go and get somebody stabilized and then connected to outpatient health, behavioral health services? Mobile crisis teams, right? Really low barrier intervention where they come to you to de-escalate a crisis. Various, NAMI, various community support groups, all of those are part of the crisis system and part of the community intercept. The community intercept and the crisis intercept goes hand in hand with law enforcement. And a key example of this is something like a LEAD program. And usually they think of intercept 0 and 1 as sort of blending together. So it's like, people will sort of float back and forth between there, and police can often use the crisis system to sort of, they can respond to something, but then move somebody into the crisis system. Harm reduction initiatives are another great example when you think about substance use. So it's saying, hey, this is a clear behavioral health problem. Normally, we could be arresting people, right, because of the United States drug laws. But really what we want to do is just prevent harm. right? So some examples of these would be, let's prevent overdoses via fentanyl test strips. A lot of countries around the world, and also New York now, have what we call a safer consumption space. I prefer to call it an overdose prevention center because that's really what you're trying to do. That's much more of a harm reduction term. It could be giving out naloxone for people, but you're really focused on reducing the harm of substance use and understanding that for a lot of these cases, the person who's undergoing harm is the person who's using. They're not really doing something that inherently harms another person. And you can think about the difference between like a malum prohibitum offense, right? Something where it's unlawful because we say it's unlawful versus something that is malum and say it's in and of itself bad. So if somebody's just engaging in personal use, we could take a criminal justice response to it. But if we're intervening at intercept 1, we're really just trying to reduce the harms that that person might experience, including formal criminal justice involvement. When you move on to intercept 1, which is law enforcement, again, it goes hand in hand with the crisis system. So you're thinking about things like dispatcher training, right? If you call 911, how do they recognize that this might be a behavioral health crisis and deploy a team that is equipped to handle that type of crisis? You could think about crisis intervention training. So this is usually training police officers or other first responders and helping them recognize what signs of a behavioral health crisis look like and helping them learn how to de-escalate it. It's also teaching them about the different resources in your locality that they can utilize if they want to deflect somebody away from the criminal justice system. You'll notice that I use the term deflect instead of divert. And I'm using deflection for a specific reason because it's preventing formal criminal justice involvement. When I think of diversion, the person's formally involved in the justice system, but we're saying we want to divert you away from a correctional response towards the behavioral health system. You can think about crisis intervention teams, and these go hand in hand with crisis intervention training. Albuquerque, New Mexico is a great example of a place that has a crisis intervention team, like a specialized police team that does things like community outreach, right? Like they're not only responding to law enforcement calls, but they have some familiar faces that they recognize, and they're actually proactively going and checking on people. Albuquerque also has the CIT ECHO program, which is sort of like continuing education for police officers who commonly deal with behavioral health, individuals with behavioral health challenges. And it lets them do things like coordinate with behavioral health professionals at UNM to get feedback on cases and how they can handle them better. Co-responder models are a big one. So deploying a team that is a behavioral health professional in line with a police officer, and whichever need looks like it's trumping at that time, that's who would take the lead. So if it's clear that it's a behavioral health crisis that's going on, the behavioral health professional takes the lead. But if it escalates to the point where public safety is being implicated, then the police officer might take the lead. So that's a co-responder model. Formal deflection in the form of law enforcement assisted diversion. So you often see this with the opioid epidemic. And a true law enforcement assisted diversion program is focused on taking individuals whose problems are clearly, again, malum prohibitum, right? They're engaging in opioid use, and even if they're caught numerous times, if it's for personal consumption and it's not hurting somebody else, they just continue to deflect that person to case management. And they recognize that the more you do this, the more likely it is that something will take hold. And really, instead of having a criminal justice response, they want people to get the help that they need to live more productive lives. This is prevalent in New Mexico and in many states across the country, but it really got its start in Seattle. And there's a great YouTube video you could watch that talks about law enforcement assisted diversion and how it came to be. Then there's informal deflection. So I like to think of this as connection with the crisis system. So a police officer encounters somebody and says, hey, in lieu of arresting you, I really think that this is a behavioral health problem. Let me take you to a crisis stabilization center, or let me connect you to this group. Moving to intercept 2, you're thinking about initial detention and initial court hearings. So this involves things like screening and referral for mental or behavioral health problems. It could involve community courts. So these are courts, and you'll notice this picture, it's not set in a courtroom. Best I can tell, this is set in some type of like school cafeteria or something like that, but it's a court that is out of the courthouse and in the community, and it's really focused on quality of life crimes where you're thinking, hey, this is probably a manifestation of a behavioral health issue. And it's preventing like true formal penetration into the criminal justice system. So you're thinking about like low-level misdemeanors where you don't really want a true criminal justice response. This also involves data sharing between systems so that you can match people with services. So how does the behavioral health system share information with law enforcement and vice versa. And it could involve pretrial supervision and diversion. So an example might be a mental health pretrial release program, which is a specialized pretrial release program that understands the needs of people with behavioral health problems and can take graduated responses and can help them connect to treatment. The intercept 3, you're thinking about jails and courts, right? So common example here, and probably the one that most people are familiar with, is something like a drug court, a specialty docket where you're understanding, hey, there was a crime committed here, but it was largely influenced by a substance use problem. So instead of incarcerating you, we want to get you behavioral health treatment. Now, they wield the ability to incarcerate somebody or to violate somebody if they're not complying with treatment. And so that's what makes it a intercept 3 intervention in a way that the community court is not. There's also mental health courts, there's veterans courts, but you're also thinking about corrections-based mental health services. So you can be thinking about medication-assisted treatment for substance use, therapeutic communities. Do you screen for behavioral health problems in county jails? So all of those types of interventions are intercept 3 interventions. At intercept 4, you're starting to think about reentry and reintegration. So Bernalillo County or Albuquerque has a great resource reentry center. One of the things that's amazing about this reentry center is that everybody who's discharged from the Metropolitan Detention Center passes through this resource reentry center. So there's always an opportunity to reach out to somebody and say, hey, is there anything that you need? Not just limited to behavioral health resources, could be as simple as, do you need a sandwich, right? But it's things like that allow you to build rapport and allow you to help people understand that you care about them and that you want to link them to treatment if it's going to be helpful for them. You're focusing on correctional treatment and reentry programs, sort of that collaboration. So maybe you have a therapeutic community, which you could think of as an intercept 3 intervention, but it's prepping you for, well, what happens when you go back out into the community? How are you accountable? How are you going to prevent relapse? And then you're thinking about other reentry programs, right? People who are actually giving you support when you leave the facility and go back to the community. It often involves connection to needed treatment and social determinants of health resources. Often it involves peer support. So think about a warm handoff by a trusted individual. So somebody who's been there before, somebody who shows that, hey, recovery can be done and I can live a productive life. And it just gives you a little bit of street cred to help build rapport and make people more open to treatment and addressing their problems. And it's something that you really want to adhere to the risk, needs, responsivity framework in, right? Like identifying that individual's specific criminogenic and behavioral health needs and connecting them to the services that are going to help diminish their risk and not giving them services that aren't going to be helpful in diminishing their individual risk. The last intercept is community correction. So you can think about probation and parole. This is really involves mental health training for community corrections officers, right? Helping people to understand the unique issues that people with behavioral health challenges face, and helping them do things like take a graduated approach, right? So you think about graduated approach with drug court, right? Just because you have a positive urinalysis doesn't necessarily mean that you're going to be incarcerated. Probation and parole officers can do the same thing, right? That might be an indication to the individual, the officer, hey, this person needs more intensive behavioral health services than I thought, right? So it's really training them to understand behavioral health needs. It often involves dockets that have a specialized caseload of people with behavioral health issues. I like to think about community conditional release programs under this lens, right? So when somebody's re-entering the community from a state hospital after an insanity acquittal, what is it that they need to be successful, right? And how do we, again, take a graduated approach, not putting somebody back in the hospital immediately, but only if it's clear that they're not thriving in the community, right? If they don't have the appropriate community supports, you might go back to the hospital as sort of like a reset, and then you can get discharged down the line. So conditional release programs, I think about like that. Community partnerships, so forensic assertive community treatment, right? Really low barrier treatment that focused on a forensic population. And summing up this particular part of the presentation, so the TLDR, as Redditors would say, at base, policy work is collective action to address a problem. The overrepresentation of individuals with behavioral health issues in the criminal justice system is a problem. Problem is capitalized for a reason. And the sequential intercept model is a conceptual framework that we can use in formulating a collective response to this problem. Let's move on to learning objective 2, the transtheoretical model. Let's talk about what that is. And most people in this room are probably familiar with it. but it was proposed by Prochaska and Di Clemente in 1984. And the basic premise is that regarding making health behavior changes, people move through sort of predictable stages. And depending on how you think of the model, it's either 5 stages or 6 stages usually. It also holds that in progressing through the stages, there are 10 processes of change that can be employed. And and movement between stages, both forward and backward, is common, right? It's expected that it's not always going to necessarily be linear. In helping to encourage change, this model also holds that you have to match the stage of change to a change process, right? So it really tells us if somebody's in this stage of change, here are the tools in my tool belt that are going to be helpful in moving this person along the continuum. When you look at the stages of change model, and again, I usually adhere to 5 stages. Some people will talk about the 6th stage, which is like the habit stage, or sometimes in different models that'll have the relapse stage. But I like to focus on, for the purposes of this presentation, this 5-stage model is going to be a lot easier to map onto the policy cycle. But you're moving between 5 different stages: pre-contemplation, contemplation, preparation, action, and maintenance. Now, what do these stages mean? In the pre-contemplation stage of change is not being considered, right? So really what you need to do is focus on raising awareness of a problem or sowing some ambivalence, right? When people become aware of a problem, when they start to feel ambivalent about it, they can move to the next stage, which is contemplation. They're actually considering making a change. At this stage of change, you want to think about moving from ambivalence, maybe I make a change, maybe I don't, to resolve, right? I'm now resolved. This is impacting my life and I need to do something about it. When you've accomplished that, you've moved into the preparation stage of change. You're actively planning change, and you're identifying appropriate change strategies. Now, it could be one thing that you do, it could be multiple things that you do, but you're making a plan that you're about to put into action so that you can make your life better. Once you have a plan and you're resolved to act on it, you move into the action stage. You're actually carrying out change, and you're implementing and you're troubleshooting different change strategies at this stage. And then once that's gone on for a sufficient period of time, you're in the maintenance stage of change, where change is being sustained over time. And really what you're focused on is evolution. How do I continue to build my skills so that I can sustain this change? This is just a nice graphic from Montrepair that sort of shows movement through the stage of change. You'll see that they have an extra stage of change, which is the termination or the habit stage, which is, you know, the way that they're describing it is like, now it's sort of second nature, right? I don't even really have to try to do it. It would actually be more difficult for me to revert back than it is for me to sustain this behavior change. And so in this particular, this is focused on health and wellness. In this particular diagram, you'll see the pre-contemplation stage. They're calling it the denial stage. And this is somebody saying, you know, I'm not really going to focus on my health. I hate dealing with money. I'm just going to work until I die. In the contemplation stage of change, they're thinking about their relatives, right? Hey, my nana lived to be 103. Maybe there's some hope for me. Preparation is, okay, what do I, if I'm going to live to 100, like, what do I need in order to effectuate that? Moving into action, you can say, they're saying this is where the magic happens. Making some healthy lifestyle changes so that you can live longer. Maintenance, you know, over time, you're sort of starting to achieve Zen. And then termination, again, as we talked about, is now this is second nature. It would be harder for me to go back to being unhealthy than it is for me to live a healthy lifestyle. In terms of the processes of change, as I said, there are 10 processes of change. There's consciousness raising, which is really focused on education. Counter conditioning, where you substitute an alternative belief to the problem behavior. Another process called dramatic relief. So you're exploring your feelings about the problem behavior and you're starting to explore solutions to that problem behavior. Environmental reevaluation. So you're thinking about, hey, how does this problem that I'm experiencing impact my environment? Thinking about helping relationships. So what's your support network look like and how do you reach out to them to help have others help you to move towards making positive changes? Reinforcement and contingency management. So this is obtaining rewards for change being made. It doesn't have to be money. It can be any number of contingencies. Self-liberation. So here you're making a choice and you're committing to change and you're really starting to feel self-efficacious about it, like that you can do it and you're confident that you can do it. Self-reevaluation, where you start to reappraise your values with respect to a problem. And you'll notice that 6th stage where it becomes like second nature, right? When you're noticing your values changing, That's sort of how self-reevaluation works. Social liberation is really feeling empowered to change, like it's actually within your control and you can do something about it. And then stimulus control, so controlling situations that trigger the problem. Each of these change processes maps onto a stage of change. So in the pre-contemplation stage of change, you're really focused on consciousness raising, dramatic relief, environmental reevaluation. When you move on to contemplation, you're going to see some of these span, right? So you're still sowing ambivalence and moving towards resolve. Preparation, you're really focused on self-liberation, right? Can I be empowered to actually effectuate some change? And then when you're in the action and maintenance stages, you're thinking about, well, how do I reward myself for these changes that were made so I can help sustain it? How do I make use of my support network? All those types of things. If you're thinking about in layman's terms, most basic terms, what's the transtheoretical model of change say? It's meeting someone where they're at, and not doing that can have iatrogenic effects. And you'll see my Owen Wilson GIF. This should sound familiar to everybody, right? Whenever somebody says, what is MI? What are the stages of change? The common parlance is it's meeting somebody where they're at. And it's a thing that's hard to understand until you've really explored it and seen it happen. Let's move on to learning objective 3. So we've talked about what forensic behavioral health policy is. We've talked about the transtheoretical model of change, but how do they inform each other, or how are they like each other? This slide is entitled the Transtheoretical Model of Change in the Policy Cycle, Same Language, Different Dialects. I want to give a shout out to a former lab mate of mine, Dr. Dan Flack. We actually collaborated on a presentation for APA, I don't remember what year it was, but it was talking about case conceptualization for psychologists and theory of the case for lawyers. And it had that title of like, are these different languages? No, they're just different dialects, right? There are some commonalities that map onto these two things. So I have two images juxtaposed here, stages of change versus the policy cycle. And again, when I'm thinking about the 5-step model for both of these maps well onto this particular presentation, but there are other ways to think about it. So when you're thinking about some of the commonalities, for the transtheoretical model, in the pre-contemplation and the contemplation stages of change, really what you're doing is agenda setting, right? You're helping to raise awareness and educate somebody about a problem, and you're starting to assess and build motivation for change. In the preparation stage of change, you're really engaged in formulation and decision-making. How do I brainstorm these solutions, and how do I select the solution that's best for this particular problem? The action stage of change corresponds to the implementation stage of the policy cycle. And the maintenance stage of change corresponds to the evaluation stage of the policy cycle. So you're actually implementing and you're troubleshooting solutions. You're starting to assess what the impact is. Are there deficit areas for this solution, and how can I remedy that? What are new solutions that I can employ? So in short, you're thinking at these two, at the action and maintenance stage and the implementation and evaluation stage, you're really focused on implementation, innovation, and evolution. So let's talk now about why psychologists are ideally situated to work in policy spheres. Really what you're focused on in the policy world is providing education about a problem and about solutions, assessing motivation and building rapport with stakeholders, and engaging in collaborative problem solving and promoting and sustaining change. And if that sounds very similar to how you move people through the stages of change, well, you're right. That's why I'm doing this presentation, right? Because the policy cycle and the transtheoretical model really do mirror each other in a lot of ways. Let's reconcile this. Let's think about this in relation to a forensic behavioral health policy issue that we talked about earlier, the competency crisis. So most of you are probably familiar with the competency crisis involving things like long wait times for competency evaluations, long wait times for competency restoration services, poor service quality, right, in terms of both evaluations and provision of competency restoration treatment, trouble providing services for special populations, right? So if you think about the fact that most competency restoration treatment happens in a psychiatric hospital, and the first line of treatment in a psychiatric hospital is medication, well, what do you do when an individual, their issue is not necessarily caused by something that's remedied through medication, right? What if it's an intellectual disability? You're not medicating your way out of that. So how do you address the needs of a special population in regards to competency? Overcrowded facilities right? Because most restoration treatment happens in inpatient facilities, we just see census loads that are very, very high, and we see these long wait lists. Provision of services that are not provided in the least restrictive alternative or in less than ideal environments. So two things there. One, not everybody who gets competency restoration treatment in a state hospital really needs to be in a state hospital, right? They're not imminently dangerous to anybody. Also, people will talk about jail-based restoration. And I don't have anything against jail-based restoration, but we did just talk earlier about, is it a little bit contraindicated to treat a behavioral health issue in a jail setting, right? You just don't have the types of outcomes that you have in more therapeutic settings. You can think about Jackson-related concerns. So how long do we hold people's charges open if they're unrestorable, right? Do we get rid of those charges? What if the charges are really serious and we still want some oversight over that individual? And also Jackson-related concerns being, how long do you keep somebody in the hospital before you determine that they're unrestorable? And then further criminalization of mental illness, right? So the number of evaluations I do where somebody is incompetent to stand trial, but it's pretty clear they don't need to be in a hospital, is astounding, right? And I really started to think about this a couple of years ago at APLS when Dr. Neil Goensmith had talked about, and it was I don't think he meant it as a throwaway remark, but it was something very quick, and it wasn't elaborated on in the context of that presentation. But he referred to competency as sort of the emergency room of the criminal justice system. And not everybody who walks into the emergency room needs to be admitted to the hospital. Not everybody referred for a competency evaluation and found incompetent needs to be restored to competency and continue to move through the justice system, right? Some people, we can just divert them to treatment because the very thing that made them incompetent is the whole reason they're involved in the justice system in the first place. And then burnout. So Dr. Ricardo did a great presentation on this a few weeks ago. Most of you on this call, if you've done, or on this webinar, if you've worked in state hospitals, if you're doing competency evaluations, you're probably inundated and overloaded with competency evaluations. You probably feel like you can't keep up. Some of you might be considering, is there a different career path for me, right? All of those types of burnout are prevalent when you're taking the wrong tack to solve the competency crisis. So let's talk about education and building awareness for the competency crisis. How do you reach your intended audience? You can do trainings. As an example, CLE trainings, right? One of the things I love to do is get in front of a group of attorneys because they're the ones who can really help advocate for things. So if I can do a CLE, if I can do a training where I'm reaching a legal audience as opposed to a psychology audience, I love doing those. Publications, and more on this in just a minute in terms of what I mean with publications. Presentations are key. You might wonder how this differs from trainings, and I often think about, a training is I'm invited in to talk to a specific audience and teach them something. A presentation, it's something I've submitted. It's like loosely peer reviewed. It's either could be at something like APLS, but it could be at like a bar conference or something like that. Upcoming in Pennsylvania, there's a forensic rights and treatment conference that Drexel University does. And it's refereed, right? But I know I'm going to get to talk to lawyers and judges at that particular conference. And then report writing, I think, is also a great way to build awareness, and I'll talk about that more in just a second. So some things to consider when you're trying to educate or build awareness. You might have to seek out these types of opportunities, right? To reach the audience that you truly intend. So as an example, I offer to do CLE trainings for attorneys in Delaware for the Office of Defense Services regarding competence to stand trial. At that training, number one, I want to talk about just competency in general and how you assess it, and what are good referrals and how might you expect certain psychopathology to impair people's courtroom-related abilities. But one of the things I really wanted to do was to highlight the competency crisis and discuss the concerns I had about it, right? Many states, the only place you're going to get competency restoration is a state hospital. And we need to change the idea that is appropriate in order to start seeing some true systemic change, right? So if I can inject that into a presentation, I'm 100% going to inject that into a training or a presentation, because I want to start changing minds in terms of how we conceptualize policy related to these issues. Peer-reviewed publications, at least the way that we think about them in a peer review, in a journal that's actually reviewed by your peers, so other behavioral health professionals. We can talk about law reviews. They're sort of peer reviewed, but they're not really by people who have a true understanding of the science of psychology. That's not the bread and butter of policy work. Peer reviewed publications are not the bread and butter of policy work. Reason being is they don't have a wide enough reach, right? So you consider things like magazines, newsletters. How do you get something in a popular media outlet? Can you write an op-ed? Is somebody going to read a blog, etc.? They have wider readership and they're much more accessible. Specifically, you can think about something like a trade magazine or a newsletter. So this should say October 2023, but just in this current edition of the APLS newsletter, there's an article in there that I co-authored with Stephanie Fulmer, Alec Russell, and Dave DiMatteo about taking charge of dismissing charges and its implications of Commonwealth versus Humphrey, a Supreme Court case in Pennsylvania for individuals found unrestorable to competency. I purposely wanted that to be in the newsletter because it's free. It can disseminate that out to attorneys and there's no paywall, there's no barrier to them seeing it, right? It's just much more disseminable than if I were to try to publish this in a peer-reviewed journal. Also might be hard to publish something like this in a peer-reviewed journal, right? Not everybody would say, hey, this contributes to generalizable knowledge. So newsletters are a great way to publish some of those things. The Law and Mental Health series is a great way to talk about things that might not otherwise be publishable, but are things that we should be talking about. Another good example, in July, there was an article published called Adjudicative Competence, a review of advances over the past 35 years and shedding light on the competency services crisis and Pennsylvania's response. I wanted to talk about this in front of an industry audience. This is an industry magazine. It specifically goes to defense attorneys, right? That's the audience that I want to be talking to when I'm talking about competency issues, right? This isn't the context of an evaluation, so I've been able to advocate for things like maybe our system's broken, maybe there's things we can do to fix it. So be thinking about where you publish, and this doesn't mean that you don't do peer-reviewed publications, right? But it often means if you think something's going to have policy implications, how do I get that over to the, even if I publish it in a peer-reviewed journal, how do I get it to the audience that I really want it to reach? You should be prioritizing reach. So as a good example, and I'm using this as an example just because of the scale of the numbers, not because of personal feelings. I know Joe Rogan is a controversial character in a lot of circles. So in 2020, so shortly after COVID had started and the tragic death of murder of George Floyd had happened, and Dr. Nancy Panza got invited onto the Joe Rogan Experience, and she was able to talk about police psychology for 2 to 3 hours. And she reached an audience probably of 10 million plus listeners. That is a huge audience for a psychologist to be able to reach. And that happened on a podcast, right? So podcasts, I don't know of any article that I've ever written or that any forensic psychologist that I can think of that has reached 10 million people. But Dr. Panza was able to do that in one podcast, which is just crazy. TED Talks are another great way to disseminate out information. TED Talks are viewed more than 3 billion times annually. All you have to do is log on to YouTube and see the viewership of some of these things. If you can do a TED Talk and you really want to shine light on an issue, that's a great vehicle to do it, right? So think about how you can get the biggest reach. In terms of reports, I like to think of education as advocacy. And I think I talked a little bit in 2021 when I was still at UNM and I gave an LMH presentation about this, about how you can use a report to educate your audience, and that education is itself advocacy. In recognition that many jurisdictions have concerns about overcrowded hospitals, they don't always want to commit somebody to a hospital just because they're incompetent to stand trial. I started thinking about, okay, well, if they want to know how could this person be stable in the community, if they're starting to think of competency as the emergency room of the criminal justice system, what information do they need to reach informed decisions? And I started just doing an assessment of community stabilization needs via the Gaines reentry checklist. Little did I know this was going to be consistent with things that were put forth by Coyce et al. In 2023. Number one, they're advocating a public health response to the competency services crisis. So this whole idea that Go and Smith put forth at APLS about just because you pop up on the criminal justice radar doesn't mean that you need a primary criminal justice response. But it's also consistent with research by Dan Murray et al. In 2023 that talked about how competency evaluations are evolving in light of the competency services crisis. It was nice to know that I was not the only person who was thinking about this as I did evaluations, and a lot of people are now employing that type of practice. You want to consider what stakeholders you're working with. So moving on, when you're assessing motivation and building rapport and you're starting to do some collaborative problem solving. So what stage of change is a stakeholder in regarding the problem? And you have to make sure that you match your interactions with them to the stage of change they're in. So for example, if somebody is not aware of the competency crisis, you have a PD, a DA, or judges who just don't understand that competency is a problem in their jurisdiction, you can't just go to them and say, let's do a pretrial diversion program, right? You have to educate them on the problem. They have to understand that here's a problem that needs a solution. Otherwise, you're going to be maybe talking to a brick wall, right? Similarly, you're not going to approach a state mental health oversight bureau for help addressing the needs of a specialized population if they're not yet adequately addressing the needs of the more generalized competency population. So if you haven't figured out your state hospital system and all of that, it's really hard to advocate for the needs of individuals with intellectual disability, fetal alcohol syndrome, autism spectrum disorder, dementia, those types of things. Think about what concerns you have to make room for. So, too often we come from the ivory tower and we say, here's a solution to this problem, right? And we just want people to accept it as gospel. But we're not often thinking about, well, what are the things that make this other person tick, this other policy person tick? If you ever work with DAs and PDs, right, you have to think that PDs are going to be advocating for their clients to get the best outcome for them. And it might not always be what a psychologist thinks is the best outcome. And when you're dealing with DAs and judges, you have to think about public safety. Right? If you're going to do some type of community diversion program, all it takes is one person being allowed to be in the community who does something horrendous, and it could be the exception that proves the rule, but that's enough to pull the plug on a program, right? So you really have to think about, how do I balance these interests and craft solutions that are going to be acceptable to all parties involved? You got to know the legal limits of the jurisdiction that you're working in. So as an example, when I was working at University of New Mexico, people had been talking about, how do we do community competency restoration? But New Mexico had, via a combination of statutory law and case law, if you don't go to the state hospital for restoration, then your charges are dismissed. So you can't really do community restoration because there's nothing to restore you to, right? What they were really cared about, though, was that people kept cycling through the competency system because they were never connected to treatment. And so we came up with a forensic navigation pilot that was focused on that. It was focused on recidivism reduction, not restoration to competency. You also have to understand the subtext of an action, right? We often assume negative intentions for people if they don't agree with us, but think about a judge who orders somebody to a hospital for competency restoration. Sometimes they don't really care that much about the competency related piece of it, right? Like, they're never going to want to see somebody in jail, but they might think this is the only mechanism I have to get somebody into treatment. So when you can start to think about the subtext, hey, everybody agrees this is a behavioral health problem and somebody needs treatment, you can have a very different conversation. Let me go over a couple of lessons I learned from internship at Springfield Hospital Center. So number one, I learned that patience is a virtue. I had a supervisor, Dr. Charles Zeitler, who, and he might have gotten this quote from somebody else, but it was that change is brought about by gentle pressure relentlessly applied. And sometimes it just takes time for an issue to ripen. So for example, they've known that wait times for competency evaluations in New Mexico have been a problem for several years. There was information published about that by the Judicial Education Center, I think from the New Mexico Sentencing Commission in 2019, but it wasn't until 2022 that they formed a commission to address mental health and other competency related issues in the state. So, even if you were sounding the alarm in 2019, you might have to wait 3 years for the appropriate momentum to be there. And small steps matter, right? I had another supervisor, Dr. Shauna Maurer, who talked about if something seems daunting, it's because the first step that you're trying to take is too big. So in New Mexico, overhauling the competency system was a huge task, but creating that forensic navigation pilot to connect people who were incompetent to stand trial to behavioral health resources, that wasn't so hard, right? That was a much smaller step that we could take that was really addressing the crux of most people's concerns. Another lesson I learned, this is from my time in New Mexico, is that you need infrastructure to build infrastructure. You can't have a community competency restoration or a deflection or a diversion program without sufficient community resources. And these include things like community motivation and buy-in. LEAD programs worked in Seattle because the community was literally calling for them, right? You also need a place that has adequate community behavioral health resources. So if it's really hard to get an outpatient appointment or it's really hard to access the crisis system, it might be very difficult to build an outpatient competency program. What if people don't have housing options, right? If somebody doesn't have stable housing, it's not realistic to think that they're going to get connected to treatment. So do you have sufficient housing options in your jurisdiction? Do you have access to low barrier treatment options? And also think about program evaluation. We as psychologists, policymakers know that good outcomes yield funding, right? An ability to scale a program. But psychologists know that program evaluation isn't just about assessing outcomes, but it's identifying barriers, it's identifying gaps, it's identifying what other resources are needed to take a program to the next level. And so program evaluation done correctly yields program improvement, not the scrapping of a program. The number of times that people scrap a program because it didn't have the exact right results is astounding, right? When really what we should have been saying is, this helped in a lot of ways, it didn't help in these ways, and here's why, and here's how we fix it. Last thing I want to talk about is strengths-based evaluation approaches. They're always motivating. So when I was doing that forensic navigation pilot in New Mexico, Scott Patterson, who works for the administrative office of the course in New Mexico, said something that really stood out to me, because we were trying to serve 30 individuals in a discrete period of time. I think it was over 9 months to a year. And I think we really had good involvement with 10 people. And so that looks like a failure, right? Hey, we tried to serve 30, we only served 10. What about these other 20? And one of the things that Scott said as a voice of reason was, it sounds like 10 people have been connected to services that they otherwise wouldn't have been connected to. And that changed the whole tenor of that meeting, and it changed my whole perspective on that program. A couple takeaways. Sequential intercept model, in my view, again, I said this earlier, it's one of the single biggest advancements ever in forensic behavioral health, right? It really gives us a good policy framework to address the problem of overrepresentation of behavioral health issues in the justice system. US psychologists have very transferable skills, and it allows you to be effective policy advocates. I'll just tell you, I use the transtheoretical model and motivational interviewing much more with policy colleagues than I ever did when I was doing treatment with clients. And in considering how you might approach getting involved in forensic behavioral health policy advancement, think of the transtheoretical model of change as a very solid framework to start from, and all the ways that it maps onto the policy cycle. Just a quick motivational meme. I think everybody, or GIF, I think everybody in here is probably at this talk because you're interested in how policy works and how you can make systemic changes that might help actually tackle some of the issues that we face in the United States. So I just want to say that we got this. Psychologists are really well prepared to do policy work. And here's some references. And with that, I will end and take some questions.
Thank you so much, Dr. Fairfax-Columbo, Jaymes, for again highlighting the different ways that we can use our expertise for broader change. I know I enjoyed seeing those parallel models of our model of change, while also the policy process. I guess as in a personal side too, I'm going to be making note of that deflection language. I hadn't really considered that aspect, but yeah, the language of how we communicate these things does have implications for the values that we're focused on here. The CEU links are posted into the webinar chat, so I encourage you to open those now. Make sure that you check them, make sure that they work for you. Save that ahead of time if they're not working for you at the moment. In the meantime, if you have additional questions for Dr. Fairfax-Columbo, feel free to enter them in the Q&A box now. We have a few questions right now, and one of them being, what recommendations do you have for educating through reports, particularly for those that work in state hospitals?
Sure. One of my biggest takeaways from my time at Bridgewater, others might agree with me on this, but I think the single most impairing symptom of mental illness is not any particular symptom that the DSM lays out, it's anosognosia, lack of insight, right? The thing that prevents somebody from realizing that they're sick and agreeing to treatment. So in reports, I would often talk about that as an associated symptom of mental illness that was preventing somebody from staying stable in the community, right? So just that little thing that I was doing there was trying to get judges to understand, hey, like maybe we have to take a different approach to this person. So as a good example, I recently had somebody call me, a probation officer, to ask about something in a report that was given to them by the Office of Defense Services. And they were asking about like low barrier intervention, right? They essentially said, I don't want to violate this. The person was not competent and they didn't want to violate the person. And essentially what they said was, you know, we've bent over backwards. We're always available. I don't understand why this isn't working. And I said, well, you're always available, but like, does he have to get to you? And they were like, yeah. And I was like, you can't expect somebody who doesn't think they're sick to come to you, right? You go to them. And then I was able to talk him through like what anosognosia looks like, what low barrier intervention looks like, and that person didn't end up in the state hospital because of that. State hospitals is a little bit more challenging because they're already in the place that where you're noticing this problem, but it did come up in Bridgewater a lot, right? Particularly for things like civil commitment, right? Like that's often the thing that I was committing somebody for was because I knew that they were going to destabilize as soon as they left, right? That the only thing that was keeping them stable was institutional structure. And the reason that they were going to destabilize is because of lack of insight, right? So you can do little things like that, like educate them on these more complex topics in simple, easily accessible language. And it just starts moving. Like once judges start to pick up on some of that stuff, they start to ask the right questions. So I hope that answers the question. It's really just giving people a more nuanced understanding of things so that they start to ask that next question and that next question that leads to a systemic ripples.
Absolutely. How about this idea about any recommendations for situations when judicial stakeholders are not only have not bought into an issue, but are instead the ones that are actual barriers for change and success? How do you, any recommendations for implementation in that situation, or what you do in that situation?
So if I'm understanding this question correctly, it sounds like that judicial stakeholder is in the pre-contemplation stage of change, where they're just like, they're either not aware of the problem or they are aware and they're turning a blind eye or purposely being obstinate. And you know, if you're thinking about the transtheoretical model, it's you can't push for something that is beyond that person's or that entity stage of change. So it really is starting to think about how do I make this person see things differently? I really like acceptance and I'm not a therapist, but like when I did do therapy, I really like acceptance and commitment therapy because I love metaphors. And there's a few people in this field, and Heath Hodges, who was at University of New Mexico, is one of them, where he'll use a metaphor and it just like blows my mind and changes the way that I think about something. And all I needed to hear was that proper metaphor so that I could understand it, right? So it might be thinking, like doing things like that, right? You have to think about how do I actually reach this person? And I'll even do things like what makes this person tick outside of work and how do I put it in that type of language? People are probably used to doing this in the context of like a competency eval or competency restoration treatment, because everybody uses the sports team metaphor, right? Judge is like a referee, prosecution's one team, defense is the other team, the two teams are competing, the judge calls it down the middle, right? Like think about those metaphors and those types of things so that you can figure out how to get the education to sink in for the person. That would be my particular advice. If that is not working and you're trying over and over and over again, sometimes the thing that is standing in your way, like change doesn't happen until it happens, right? Political offices turn over, new people come into power. Generating your list of solutions and then injecting them once there is a little bit of room for change can also be huge. Sometimes it is the waiting game, unfortunately.
Thank you. Yes, and I will second that. Dr. Heath Hodges being the king of metaphor aspect there. In thinking about that, a question that came to mind here in thinking of past talks about forensic behavioral health policy issues, whether we draw the parallel to the pre-contemplation and contemplation stages, a thing I'd anticipate some audience members might believe here or feel here in thinking about this is some concern about reaching out, not merely if they primarily do say evaluations for court or where they testify in court, not whether certain advocacy outside would even necessarily impact or bias their interpretations, but even the optics of it and how that could impact issues that are challenged to them on the stand or how they're presented in court. Just the mere appearance that by reaching out in these other areas outside of the court system, I am no longer as impartial a person as the court would like me to be. Any advice or considerations for people in the audience that might be hesitant to reach out given their work in the court system?
So that is a question that I think has come up in the past in the Law and Mental Health series. And look, when you're a forensic psychologist, you reach objective opinions based on the data that you have in each individual case, right? There are plenty of people that I evaluate and I find to be competent, right? It's not like every person who has a mental health issue, I think that they're incompetent and shouldn't be in a state, but incompetent, but shouldn't be in, you know what I'm trying to say. So that's the number one thing I would think of. It's like, this goes through a process, right? I reach an opinion about somebody objectively. I often have to I separate out, like, here's the opinion I reach for this person, and it might have a negative outcome. And the only thing I can do to make it not have a negative outcome is to change the system, right? But I'm purposely parceling those two different things out, right? Like, and so that's how I would answer that question, is when I'm in an evaluator capacity, I am objective and I'm responding to the individual and I'm playing within the constraints of the system. But, if, like, I'll use another sports team analogy. If you have a football team that has a really crappy defense, but a good offense, you don't then say, I don't want to change my defense, I'm only going to lean into the offense, right? That's how you lose Super Bowls, because defense wins championships. So, like, that is a good metaphor, I think, for use, is like, I'll play within the constraints of what I have to play in right now and focus on those particular strengths. But I can very easily see where the deficits are, and it's not a problem for me to then go do things to, like, no head coach is like, I'm not a good coach if I go work on my defense when I already have a good offense. So I hope that answers that question. You just have to be able to, like, you just have to be willing to say that on the stand, right? I'm wearing two different hats when I do these things.
Separate hats. Gotcha. Thank you. Somebody asked when you referenced near the end the forensic navigator program, if the forensic navigator program ever assists incompetent defendants to access restoration services, and any examples of that.
So the specific one that I'm thinking of in New Mexico, the reason we had a forensic navigation program instead of an outpatient restoration program was what I said before. They didn't have any charges. Like, once they were found incompetent, their charges were going to be dropped. So really the idea was, at the time that the charges are being dropped, can we have somebody meet them who engages with them and ask them if they would be happy to be connected to any services. When I think of navigation, I'm often thinking of people who are just straddling both systems so people don't get lost. People use Navigator in very different ways, I think, depending on where you are. Good examples would be, like, I think Colorado has a pretty good outpatient, like, competency restoration / diversion deflection program where they're using some navigators. So I would look to Colorado maybe as a good example. I've seen presentations that they've given. The other question, though, is, what does restoration look like, right? When we use the word restoration, like, technically it should mean, how do we restore somebody to the point where they can then go through the adjudicative process, which is a criminal justice process. Sometimes you don't care that much about, and you care about that if you want somebody to answer for something that they've done. If you're acknowledging this is really more of a behavioral health problem than a criminal justice problem, then when you say outpatient restoration, probably what you just mean is, I want you connected to treatment. I want to help you stay stable. I want you to help you live a better life and not circle back around into this system. So I would think, and Dr. Perillo, I'm glad that you mentioned this earlier. I've learned to be very particular with how I say things so that there's not a risk of it being misinterpreted. I am not that great at it. I'm still working pretty hard on saying exactly what I mean. But that is the thing that I've generally noticed, is when people say outpatient restoration, they mean a bunch of different things. A lot of people just mean, I want this person connected to treatment. I don't really care if they ever have a criminal justice response. And I see that there's one other question about how important is coercion. Let me give you my quick thoughts on coercion. I think about it like levels of care, right? When somebody's civilly committed to a hospital, it's because they don't want to be voluntarily admitted, right? But a lot of people go into hospitals, get stabilized, and then realize, oh, there's a real problem that I have to address here, and I want to make sure the appropriate supports are in place when I leave. I think coercion can be really important if there's no other mechanism to get somebody on board with something, right? So a good example in a policy sphere is working with police, right? An individual police officer at the street level might not buy into that behavioral health issues are a problem and they should have a public health response. It doesn't really matter if command buys into it, right? Because command is then going to tell all the officers, well, you have to do this, right? So coercion, I think, can be important. The thing I would try to make sure, though, is that just because coercion gets your foot in the door, there should still be things that you work to do to make the motivation for change intrinsic instead of extrinsic. So that's my answer to that question. It's a good tool to use if it's the tool that you need, it's always better to try to get people to see the light, even if you've had to start through a coercive way.
Well, thank you so much, Dr. Fairfax-Columbo, Jaymes, again, for helping us look at the different ways that with the training that we already have, in addition to the expertise that we have, and how this might be able to help us make impact on the broader systems that we navigate in our professional lives day in, day out, and the different ways that we can make an impact as forensic behavioral health experts. And always, thank you again. It's an honor to have you joining the series and returning here.
Yeah, thank you for the invitation.
Yes, that wraps up this week's Law and Mental Health series with the University of New Mexico. Stay tuned next week when we have Dr. Jenny Chan, who will be going over using interpreters in forensic evaluations. We hope to see you again. Until next time, take care.